Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Today we're going to be talking about diffuse parenchymal liver diseases. We'll begin with hepatic steatosis, then move on to iron overload disorders, amyloidosis, and Wilson's disease. We'll conclude by reviewing CT attenuation patterns that help differentiate these entities. Hepatic steatosis, or fatty liver, is a spectrum that ranges from simple fat accumulation to steatohepatitis, which includes inflammation, and this may even progress to cirrhosis. Over 25% of the population is affected, with about 5% having steatohepatitis. Steatosis can appear in different patterns. You can have it diffuse, you can have it focal, geographic, or even nodular. Focal steatosis often occurs in the gallbladder, fossa, periportal regions, and along the falciform ligament. Ultrasound shows increased hepatic echogenicity compared to the kidney, compared to the spleen. Normally, the liver and the kidney should have similar echogenicity, liver and spleen as well. Steatosis also causes sound attenuation, making deeper structures harder to visualize. So this image is an ultrasound image, and it shows diffusely increased echogenicity of the liver compared to the renal cortex. We don't have the spleen in this view, but at least we can see that the liver is brighter than the kidney, suggesting a possible steatosis in this liver. On non-contrast CT, the liver becomes hypoattenuating compared to the spleen. Traditionally, when you have a 10 Hounsfield unit difference, that's the threshold, but even a 1 Hounsfield unit difference may be significant. Fat attenuation is around negative 100 Hounsfield units, and so it makes sense that if the liver is going to be filled with fat, its attenuation value is going to generally reduce. So this image shows a diffusely hypoattenuating liver compared to the spleen in a non-contrast enhanced axial CT scan of the abdomen. MRI, especially in and out of phase sequences, is more accurate than CT or ultrasound for detecting steatosis and estimating severity. You can use the intensity values and the amounts of signal drop on the in and out of phase images to tell you how much of fat is within the liver, what percentage of fat is within the liver. However, biopsy remains the gold standard, especially for diagnosing steatohepatitis or early fibrosis. So in this image, we see an in and out of phase image which demonstrates diffuse signal loss of the liver parenchyma on the out of phase image when compared to the in phase image. When water protons and fat protons are present in the same MR voxel, the fat and water signals are summed in the in phase image and they are cancelled out or subtracted in the out of phase images, leading to a decrease in signal intensity. Focal fat doesn't cause mass effect. Vessels are seen to run through it without displacement, and often occurs at typical sites. We mentioned some of them at the beginning: the gallbladder fossa, falciform ligament, the periportal areas, and it appears hyperechoic on ultrasound. It will appear hypoattenuating on CT and will show signal dropouts in out of phase MRI images. So this image shows focal fat on both MR and ultrasound. We see a mass-like region in hepatic segment 4 pointed to by the arrows, and this area demonstrates loss of signal on the out of phase image focally here. On the ultrasound, we see this focal area of hyperechogenicity, and all these represent focal fat. Iron overload leads to T2 hypointensity on MRI, particularly when compared to paraspinal muscles. So the paraspinal muscles are the reference. If the liver is looking darker than the paraspinal muscles on T2, you should be worried. There's also signal dropout on in-phase imaging. That's opposite to steatosis, where you rather have dropout on the out-of-phase imaging. For hepatic iron overload, you rather have the dropout on the in-phase imaging. Let's look at the two main types of iron overload, being the primary and secondary hemochromatosis. So primary hemochromatosis is a genetic condition with excessive GI iron absorption. So the iron now deposits in the hepatocytes and other organs except the reticuloendothelial system. Okay, that is very important to remember. It will help us differentiate the primary from the secondary. The reticuloendothelial system is not involved in primary hemochromatosis. So MRI will show hypointensity in the liver, the pancreas, but then the spleen and then the bone marrow would appear normal. Again, because the reticuloendothelial system is not involved. Treatment is via phlebotomy. So this image is a case of primary hemochromatosis. It's an axial T2 weighted MRI and it demonstrates diffuse low T2 signal in the liver and the pancreas. But you can see that the liver is very dark compared to the paraspinal muscles, which are also dark, but the liver is significantly darker. Dark liver, dark pancreas, normal looking spleen, primary hemochromatosis. Then secondary hemochromatosis occurs due to transfusion or ineffective erythropoiesis. The iron ends up depositing in the reticuloendothelial system, including the spleen and bone marrow. The pancreas is spared in this case. Remember, pancreas was not spared in the primary. When reticuloendothelial system capacity is now exceeded, then the hepatocytes then also start to accumulate the iron, and that would put them at risk of cirrhosis. So in this case of secondary hemochromatosis, it's a multi-sequence MRI and it shows diffuse low T2 signal in the liver and spleen with associated signal loss on the in-phase imaging. So we have our in-phase, we have our out-of-phase MRI, and we can see that here on the in-phase, the liver is rather darker, and on the outer phase, the liver is a little brighter. You can also see that on the T2, the spleen is also looking very hypointense, just like the liver, but the pancreas is not looking hypointense in this shot. The bone marrow is also looking very dark. All these are pointing us towards secondary hemochromatosis. And this was from iron deposition from hemosiderosis who had transfusion dependent anemia. And it makes sense, when you have broken down red blood cells or abnormal red blood cells, they are sorted out or handled by the spleen, reticuloendothelial system. And so it makes sense that in cases of hemosiderosis and transfusion related, secondary related causes of iron overload, the spleen and the reticuloendothelial system would be involved. So in primary hemochromatosis, pancreas is affected. P for P, primary for pancreas. And in secondary hemochromatosis, the spleen is affected. S for S, right? Just something to help us remember. MRI would show diffuse T2 hypointensity and signal dropouts on the in-phase imaging compared to out-of-phase imaging. Both primary and secondary are T2 hypointense, and they will show signal dropouts on in-phase. Amyloidosis causes abnormal extracellular protein deposition in the liver. This may appear as focal or diffuse hypoattenuation on CT. It's rare, but it's important to consider as a differential. Wilson's disease is an autosomal recessive disorder of copper metabolism. It leads to copper buildup in the liver, in the basal ganglia, and in the cornea. The liver may be hyperattenuating on CT and will develop multiple nodules, hepatomegaly, and cirrhosis. So to summarize, a hypoattenuating liver on unenhanced CT suggests fat. Steatosis is the most common cause. Other causes of hypoattenuating liver include amyloidosis, but this is very rare and is less frequent. When we come to hyperattenuating liver on non-contrast CT, that's a liver above 75 Hounsfield units, usually suggests iron or copper overload. And common causes include hemochromatosis, certain drugs like amiodarone, Wilson's disease, glycogen storage disorders. All right, I hope this has been useful. Thank you very much for your attention. If you found value, give it a like, share to someone you think would appreciate this. Subscribe if you have not subscribed yet. The next thing we'll talk about is cirrhosis. I'll catch you in the next one.